identify that. So the rural community is kind of always having this ongoing challenge. So introducing our research team, we are a multidisciplinary and research team, which is composed with researchers from the School of Nursing and from the Faculty of Management, and Cherisse is our wonderful project coordinators and with the background in psychology. And also we have colleagues from social work and then the computer science and maths departments. And then so all together, but that is kind of by forming this multidisciplinary team to really kind of by pushing ourselves to think outside the box and to break the silo. I think that's one of the very important for the purpose, forming a multidisciplinary research team. So additional member for that, we have John Botteroff, and then so as our advisors and also wonderful mentors. We also have Mike from Sociologies and also Rob from the School of Medicine in the UBC Vancouver campus, and my colleagues like Jennifer Davis from Management. So we are actively kind of like thinking about the next generation. So we have Bessie as our postdoc fellow working with us at this moment. And also in the past couple of years, but that we all kind of like working closely with different trainees from undergrad level and through different disciplines and also funding mechanisms to the graduate level through the traditional funding platform. So the research goal is, as I mentioned earlier, for that we want to partner with the rural community to develop and implement rural-centric technical and social enterprise solutions. So we have to think not just like relying solely on the government support, but also thinking about how we can creating those like self-sustainable mechanisms to supporting the health need, and then in these rural communities. We also want to co-create a research excellence, and then we learn from each other. I think that's very important rather than we always be inventing the wheel. So creating a hub for research excellence and also promote rural health and healthcare equities is one of our purpose, because we found that it's just like a lot of case when we talk about the healthcare innovations with that, they didn't really put particular emphasis or interest in the rural communities with that. To some extent for that because of the economic upscales, to some extent because they just like don't understand the kind of like the landscape. So to me, for that, just like that's very important to really reset the equity landscape and enhance like and health and healthcare for rural disadvantaged people, in particular the children and youth populations, the indigenous communities, and also the older adult with chronic disease. So in the next few slides, but then Cherisse will join us to talk about some of our ongoing projects. And Cherisse, please take over the stage.
Thank you, Eric. Welcome, everybody. So as Eric said, the goals of our research cluster were really to co-develop solutions with community. So this group came together, these multidisciplinary researchers, and it kind of came up this morning in the morning coffee about this idea of research kind of having this problematic power differential. And that was something that we were cognizant of and wanted to avoid. So we wanted to really have some community-driven solutions. So we're hoping to find some technological solutions and some social enterprise solutions, but we just didn't want to come from like a top down and say, hey, we know it all, you know, we're going to apply these urban solutions that'll work. And that's not what we wanted to do. So we really wanted to co-develop and have some community-driven solutions. And so in the first year of the projects, we proposed this concept mapping process. And so concept mapping is an approach that's aimed to surface and synthesize solutions. So it allows for individual brainstorming of ideas, but also a quantitative statistical method to synthesize those ideas. And then we call this a mixed method because we had some qualitative component as well to really validate the final solutions with rural community members who had generated them. And so if you think of like focus groups or interviews, kind of they're useful for exploring participant views. Concept mapping allows for kind of individual brainstorming, as well as kind of mapping complex concepts to reveal like an underlying structure that was not directly identified by individual participants. So I'll tell you a little bit more about that in the next slide. So first, in step one, participants completed a short online survey asking them about their ideas for action. So a company called Polygon Research Incorporated provided the concept mapping platform, which allowed for a primarily online asynchronous concept mapping process so that participants could kind of join us regardless of their geographical location. So in this idea generating exercise, 34 community stakeholders, individually answered the question. If you could click Eric. What are possible technological solutions that could address the health and well-being issues of people living with chronic disease in rural British Columbia? So we had 34 community stakeholders generating ideas, technological solutions in response to that question. So we had this individual brainstorming of ideas, and in total, there was 84 ideas, different ideas that were generated. And then we went through all those ideas and distilled them and combined similar ideas and removed duplicates. So there was, for example, a lot of ideas surrounding the idea of affordable, high quality internet and cellular coverage is needed in rural areas. And so that idea was kind of compiled into one statement. Then those ideas, those 10 statements in step 2, 16 participants returned to kind of rate those in terms of their importance and feasibility, and also to sort them into groups. So they individually sorted the 30 statements, the final 30 statements, into groups. And then in step 3, we had a statistical process called non-metric multidimensional scaling to kind of merge the groups that individual participants sorted them into a unified set of groups. So kind of the average grouping of groups, if that makes sense. And we had 10 participants join us for a virtual session to kind of look at that and kind of validate that final solution and name the different groupings of clusters and kind of discuss what the meaning of them were. Thanks, Eric. So these next 2 slides are really dense. You can see the actual ideas and the actual clusters. So a solution with 6 clusters was kind of the best statistical solution based on how the participants had sorted all the 30 statements. And we came up with this 6 cluster solution. Participants discussed the ideas and agreed upon representative names for each of the clusters or groups of ideas. The first one, cluster A, was technological solutions and applications. This captured diverse technological applications that participants interpreted as being about developing technological solutions to help communities gain access. So if you could just click one more time, Eric. An example of what somebody said during the session was, our tertiary hospital will be a good 4-hour drive. It's an overnight trip, which means there are accommodation expenses as well. So in some cases, people just don't engage with those visits. So this cluster was really about technology providing access to care. Then in cluster B, the equitable access regardless of location, the ideas all surrounded ensuring patients could access care in a variety of settings, including digital solutions for timely, on-demand, 24/7 care, as you can see in that final statement 23 of that group. The staff and patient support cluster, cluster C, involved training and support for both patients and healthcare providers so they can use the available solutions. If you can click one more time, Eric. So here's how one participant explained this. One of the things I've seen is that we've got this technology, but if one person wasn't there, that one person who knows how to use it, then nobody gets to use the technology. If the technology is there, there has to be people that can access it for the patient. So some of these ideas here just around, you know, having that support for both staff and patients, or some training available so that the technological solutions can be used. Cluster D, the 4th cluster, was simplify user tools for healthcare, and this included a range of ideas ensuring digital tools and solutions are simplified so that patients can use them. If you can click one more time, Eric. Simple and reliable are not the same. You can reliably have a really complex system that no one can use. When you're the user, what you want is almost a manual button that you can just push start and it works. It's like your car, right? That's a very complex piece of equipment, but it's had a lot of user input of people saying things like, I don't want to go out and hook up a battery and all the rest of it. So these days you can just sit in your car with a thing in your pocket, like a key fob, and just your car can just start. And so it's part of designing the technology not to suit the technology developers, but to suit the end user, simple access. So that's what this cluster, what they saw this cluster as really being about. Simplifying the technologies and simplifying the user experience with those technologies. Collaboration among healthcare professionals, cluster E, captured technologies for improving provider-to-provider interactions, along with using technology to support team-based care. And finally, overcoming challenges to technological linkages between systems, health records, and networks, cluster F, encompassed interoperability of health systems, as well as the use of electronic health records to improve quality of care. So if we look at the organization of the 6 clusters visually on what's called a concept map, we can begin to see the relationships between the clusters of items. So this is where it became important in terms of how people grouped them and where the clusters all grouped in relation to one another. So if you look at kind of the items at the top of the map, they were all more about the development of new technologies. And items at the bottom highlighted more the importance of the human aspect of technology use, including ambassadors, training, and support, which were seen as critical for connecting patients with the technologies. For example, cluster C itself is that cluster called staff and patient support, including item 13 at the very bottom, which was provide education, training, and support for rural staff to ensure they can use the technologies available to them. If you can click one time, Eric. An example quote from a participant was, and that's where I go back to the ambassador, to the actual person who knows what's going on and can push the buttons and can ensure that when I want to talk to a specialist, I can talk to the specialist and not worry about clicking and whatever else. So in discussing the map, we also had participants rate all the individual items in terms of importance and feasibility. And this figure presents all the abbreviated statements, according to the mean ratings of importance along the x-axis and feasibility along the y-axis. So the highest rated statements in terms of both feasibility and access are captured in what's called a go zone at the top right. In this work, it's important to note that all the items are rated kind of a 3 or more in terms of importance. So there may be solutions that are important to consider, despite what that kind of term go zone suggests. All of these statements were kind of seen as important. So here it's evident that the statements in the top right were not all from a single cluster. So you can see we've color coded according to the color of their cluster, and nearly every cluster is represented here, suggesting that no one solution was given priority. So this could reflect the complex interrelated challenges often faced by rural communities and the need for multi-level solutions in underserved rural populations to address the lack of equitable access to healthcare. So overall, we heard that technological solutions cannot stand alone. Along with access to reliable, affordable, high-quality internet, essential for technological solution, digital skills training could support uptake of any technological solution. So we need multiple things here when we're talking about technological solution, is something that we learned from rural community stakeholders. So we approached it saying, hey, how can technological solutions, be used here? And we really heard back that it's going to be a complex interplay of things, including training. So our plan, based on that initial concept mapping project, is to build future projects based on these results, based on what we heard from rural community stakeholders. And an example here is one of our concept mapping stakeholders who was involved, Glue Society. It's a Canadian nonprofit organization that offers free digital skills training for Canadian seniors. And we've partnered with them and secured a SSHRC Partner Engage grant. So in this project, we're assessing implementation of their free training program in rural settings over the next year. And we plan to apply for future SSHRC Partnership Development Fund to continue to expand this partnership, and specifically to begin to address e-health literacy, or what skills can support health technology adoption, such as virtual care. Next slide. I see, Eric, we're getting low on time, so I'm just going to go through the next slides relatively quickly. Virtual care, of course, came up in our concept mapping study as a promising solution to address rural inequity in healthcare access. And indeed, COVID-19 has driven a massive shift to virtual care, but there's still digital disparities. And virtual care used to its full capacity, like with video, requires adequate broadband access, which is often limited in rural settings. So we, next slide, Eric, we decided to do a survey of communities, both rural and urban, to find out about rural internet quality and virtual care satisfaction, and gather participant suggestions for improving virtual care delivery. So we had 501 community members participate, and 47% of them were rural. Next slide, Eric. We found out that virtual care use was very high, with over half the participants reporting having just started to use virtual care since the onset of the COVID-19 pandemic. But as you can see on here, only just under 30% had never used virtual care, and over 50% had just started using since COVID-19 began. With respect to mental health services in particular, we looked at pre versus during COVID-19, and we asked people to just self-report that to remember back, whether they had needed online mental health programming or video or phone mental health services. And we see that the need for mental health services had increased pre to post COVID in both rural and urban participants, but the need was even greater in urban participants, in fact. And encouragingly, it's not shown on this slide, but we asked participants about their access to these services, and both rural and urban participants reported having greater access during compared to before COVID. So that was encouraging. Then participants were asked to describe any unmet health or wellness needs they had since the start of the COVID-19 pandemic. And when describing unmet health or wellness needs, participants described reduced or limited access to care in general. As you can see in this first quote, ruptured appendix was undiagnosed and ended up in emergency, lucky to be alive. But they also described limited health promotion and prevention options. And the second quote here is, I have not been able to schedule my routine cancer screening exam with my physician. I also have not had a massage in over 18 months, and it was over a year before I went to get my teeth cleaned. So really this limited access to health promotion or prevention options. And finally, lack of mental health service options. So we heard from a lot of people about, even though there were mental health services available, they seem to be more for crisis type situations. So this last quote says, although there were mental health services available, I find that the majority of the free ones are crisis support, not ongoing mental health support. Finally, there was a great deal of interest in continuing to use virtual care solutions among both rural and urban participants. So the rural here are in the blue lines and the urban in the gray lines. And there wasn't significant differences between these, but we've just presented them more for interest. But you can see quite a large percentage of people interested in continuing to use virtual care post-pandemic. Both rural and urban, there were themes that virtual care is good for non-physical exams, things like prescription refills, but not as a replacement for in-person care. And so the top two quotes here kind of reflect that telehealth should not replace primary care, but complement it. And simple things like medication and prescription refills, it's good for. And the benefits, unfortunately, the benefits of virtual care were there, or good, fortunately, they were there for both rural and urban participants. But unfortunately, rural participants who stand to benefit the most from virtual care and that increased access to care also reported things like the ability to use virtual care is compromised by inadequate internet. All right, and I will turn it back over to Eric to take away the last few slides.
Thank you, Cherisse, for that. Just I keep it extremely short for that. So as I mentioned earlier, for that, our goal for this web research cluster is to create a center for research excellence on community-based initiatives, including the inclusion, innovations, components for that. So we want to really kind of connecting the researchers and also the innovator nonprofit organizations or the private sector to co-explore or to adopt this interdisciplinary research approach and collaborations to really kind of turn that into actions. So future research directions for our clusters really focus on explore rural community experience using different focus group or other research technique, and also partner with organizations and also the community to really build the momentum to enhance kind of a rural health equity, and also really think about like to examine the integrated determinants of health, which is combinations of social, political, corporate, and commercial. And then so here is one of our work in progress type of work. Here's for that. So I think if you're working in the health sectors, social determinants of health is pretty much familiar to you. But at the same time for that, and we do have other alternative frameworks, which is called the political determinants of health, mostly from the US for that. And also commercial and corporate determinants of health is really guiding us to think about what organizations and also the market activities can impact our health. So what we are proposing here for that is building this integrated framework, combining all these four aspects. Maybe future, we might have more dimensions to really think about how we can meaningfully engage the individuals and also the community to to address rural health inequity in our studies with that. So having said that, we would like to close and then our presentations with these open-ended questions. So what potential opportunity for future collaborations can you envision with the research team that's us here for that? And what challenge you're facing? And then so I would like to open up the floor for any discussions. But thank you, Andres, and thank you, Holly, for managing or coordinating our presentations today. And thank you for joining us.
Great, great, thank you. We do have 2 minutes. Are there any questions in the group?
So I want to quickly, well, thank you. And then so to say that for that, if you're interested in by checking out some of our publications, and then we have some under review for that, but we do publish a few articles about the COVID impact. So feel free to check this out. The presentation will be available. And then for all the participants here for that. And also feel free to reach out to us and checking out our information. So that would be wonderful to seeing your input or maybe sharing your insights and grab a virtual cup of coffee with you to talk about issues and opportunities here.
Great, thank you very much. Okay, so our next presentation, we have speakers Diane Duzmier-Farland, and an independent researcher, Gabriola from the Gabriola Health and Wellness Collaborative. And their presentation is on from the global health impacts to community-based health solutions. And we'll give a couple minutes for them to arrive. And Holly is here with to help with technology and myself as a facilitator.
I just want to say thanks again, Cherisse and Eric. That was a fantastic presentation. So really enjoyed it, and hope to connect with you afterwards as well, because I think you had some great methods in that. And yeah, I would love to learn from you.
Thank you.
Holly, have you received slides or from our next presenters?
Yeah, so I think you can stop recording just to make sure that it's a division.